Good morning. I am Professor Udairalapanav. Today we are going to start the series of lectures on cardiovascular diseases. Today's lecture is on symptoms and signs of cardiovascular diseases and examination of cardiovascular system. This first lecture is very important for you because based on this lecture, you will get short cases, long cases in your exam. Also, you will come across some MCQs based on this lecture. Taking history is vital in clinical medicine. History is the richest source of information concerning the patient's illness. It establishes a bond with patient and a doctor. It allows evaluation of the impact of the diseases. Look at this picture. What are the information you can gather by looking at this picture? You can see a middle-aged or elderly person holding his chest with his right hand. His facial expression shows he is in some agony. And what is the situation? Most probably, he is in outdoor environment. Most probably, he is walking outside for exercise and he developed chest pain. So, when you get a chest pain, main thing that you have ruled out is whether it's a cardiac chest pain or whether it's related to acute coronary syndrome. But you have to remember there are so many other causes which can give rise to chest pain. For example, it can be non-cardiac intrathoracic structures like presence of chest infection like pneumonia, mediastinitis, pleurisy can give rise to chest pain. Also, musculoskeletal pain also can present like a chest pain. Intra-abdominal viscera like stomach, gallbladder, pancreas can give rise to chest pain. Sometimes chest pain could be due to functional or factitious chest pain. When you have a chest pain, you have to take a history to identify the nature of the chest pain. By taking a detailed history, you can identify the cause of chest pain. When you are taking the chest pain history, you have to ask about the location, radiation, character, aggravating factor, relieving factor, time relationship, and duration of the chest pain, and settings in which it occurs and associated factor. So sometimes chest pain is associated with nausea, vomiting, breathing difficulty. Breathlessness or dyspnea is another symptom you come across when you are dealing with the patient with cardiovascular diseases. What is dyspnea? It is an abnormal or uncomfortable awareness of breathing. Regardless of, regarded as abnormal only when it occurs at rest or at level of physical activity not expected to cause it. So diseases which can give rise to dyspnea are cardiac condition, pulmonary causes, and chest wall problem, and also anemia can give rise to breathlessness. Exertional dyspnea is when breathlessness come on exertion and it settle with rest, commonly due to heart failure or lung diseases. Orthopnea is a breathing difficulty on lying flat. It's a symptom of left ventricular failure. Why do you get dyspnea or breathlessness? Present like orthopnea, it is due to redistribution of fluid from lower extremities of the body to the lung tissues. What is paroxysmal nocturnal dyspnea? That is a variant of dyspnea. Patient awake from sleep, especially in the night. Patient goes to sleep and around 2 o'clock in the morning suddenly gets up with breathing difficulty. And same time, person can develop cough which may and producing a white frothy sputum. It is a manifestation of left ventricular failure. Edema. Edema is another symptom of cardiovascular diseases. Edema can be categorized as a peripheral edema and central edema. Peripheral edema can be due to various causes: chronic heart failure, liver diseases, kidney diseases can present like a peripheral edema. It is mainly due to excessive salt and water retention. Especially if the patient is mobile, you can see the edema at ankle, lower legs, thigh region or lower abdominal region. If patient is recumbent or sleeping all the day, you can see edema over the sacral areas. So what are the causes for peripheral edema? As I mentioned, cardiac failure, chronic venous insufficiency, hypoalbuminemia due to nephrotic syndrome, liver disease, protein-losing enteropathy, drug-retaining sodium, for example, protocortisone and non-steroid anti-inflammatory drugs, and increasing capillary permeability, especially due to nifedipine-like antihypertensive treatment. Palpitation is another common complaint of patients. What is the definition? It is unpleasant awareness of forceful or rapid beating of your heart and caused by disorders of cardiac rhythm and rate. For example, atrial fibrillation, atrial flutter, and extrasystole can present like a palpitation. These attacks occur abruptly and you may feel like a rapid heart rate with regular or irregular rhythm or sometimes isolated jump or skip beats. And it has to be independent exercise or excitement to cause the symptom. Palpitation can associate with the tobacco smoking, coffee drinking, tea drinking, alcohol, epinephrine-like medication, aminopiline, monoamine oxidase inhibitors, and clinical condition like thyrotoxicosis, anemia can present like palpitation. If middle-aged lady coming with flush and sweating and palpitation, you have to think about whether this is a menopausal symptoms. Syncope. Syncope is a sudden temporary loss of consciousness, and it is due to and they show spontaneous recovery. And there is no need of electrical or chemical cardioversion, and it is due to sudden vasodilatation or sudden fall in cardiac output or both simultaneously. Cough is another common symptom related to cardiovascular and other system diseases. So when it is cardiovascular, you can get pulmonary venous hypertension present like a cough, and also interstitial and alveolar edema develop in heart failure can present like a cough, and pulmonary infarction and compression of tracheobronchial tree can present like a cough. So depending on the nature of the sputum, you can identify the cause of cough. If it's a pink frothy sputum, suspect pulmonary edema. If bright clear mucoid sputum, it could be viral infection or long-standing bronchial irritation. Thick yellowish sputum, suspect the infection. Susty sputum, think about pneumococcal pneumonia. Blood streak sputum, think about TB, bronchiectasis, lung carcinoma, and pulmonary infarction. Fatigability is another non-specific symptom of cardiovascular disease. It is commonly seen in patients with impaired cardiovascular function. It is a consequence to the reduction of cardiac output, and there may be associated muscle fatigability and weakness. Drugs like beta blockers also can give rise to fatigability, and sometimes excessive diuresis due to diuretics leading hypokalemia can give rise to fatigability. Other symptoms related to cardiovascular system are nocturia, anorexia, abdominal fullness, right upper quadrant abdominal pain, weight loss, and cachexia. After completing your history, then you have to think about examining the patient. I had to mention some important thing here. If you are getting a very bad patient or ill-looking patient, you have to do history taking, physical examination, and stabilization of the patient at the same time. But if the patient is stable, you have time to do the thorough physical examination. When you are doing the physical examination related to cardiovascular system, general examination is important. So by doing the general examination, you can gather a lot of information. So start from top to bottom. If you detect pallor, think about the anemia causing or precipitating the cardiovascular symptom. Cyanosis is a buoyant discoloration of mucous membrane. Cyanosis can present like a central cyanosis or peripheral cyanosis. And look at patient BMI. Obesity can cause sleep apnea or other cardiovascular related problems, especially hypertension. And look for features of hyperlipidemia like corneal arcus, xanthelasma. Look at these two pictures. First picture shows patient with a partial ptosis, frontal baldness. And if this kind of patient is there, think about whether patient is having dystrophia myotonica. And they can present like electrolyte abnormalities and rhythm disturbances. The second picture, by looking at this patient, you know this is a patient with acromegaly. So acromegaly patient can present to you with high blood pressure. So facial abnormalities are important in clinical medicine. And if someone coming with high arch palate, some visual problem, and very high stature, then think about the Marfan syndrome. If your patient is having unusual facial appearance, think about congenital heart disease. Finger cupping is a very common symptom. And related to cardiovascular system, cyanotic congenital heart diseases, infective endocarditis can present like clubbing. Splinter hemorrhage also can secondary to trauma and infective endocarditis. And if you come across a patient with moist, cold palm, think about anxiety. If the patient is having moist, warm hands, think about the thyrotoxicosis. So this picture summarizes the things that you have to do during the general and systemic examination of the cardiovascular patient. So these pictures show some clinical features or physical symptoms that you have to look in a patient with cardiovascular diseases. So this shows clubbing, and here you can see the cyanosis also, bluish discoloration. So it's a clubbing and cyanosis. If you come across this kind of patient related to cardiovascular system, think about cyanotic congenital heart disease. So this picture shows the arcus. So if the arcus occur in a young patient, it is a arcus journalisticus, and it is a feature of the hyperlipidemia. And if you see this kind of arcus in all people, it is a arcus senilicus common in all people. And these are the xanthelasma you can see on the eyelids. So this is a feature of the hyperlipidemia. But remember, people having hyperlipidemia not essentially have to have this kind of abnormality, or if someone is having xanthelasma, that always not essential to have high lipid in that patient. So this is the eruptive xanthoma, another feature of dyslipidemia, and these are the tendon xanthoma. So you can see again, patient with hyperlipidemia, you have to suspect these clinical symptoms and signs. And looking at this palm, you can see yellowish discoloration and some kind of deposit on the palm. So this is a palmoxanthoma. So this is another physical sign that you have to check. It is a splinter hemorrhage. So these splinter hemorrhages are non-specific, non-blanching, linear bluish, sorry, linear reddish brown lesion found under the nail beds. Usually do not extend the entire length of the nails. So it is localized to some distal areas. Oscillus nodes, again, very interesting. They are more specific to endocarditis. They are painful and erythematous nodules located on the palm of fingers and toes, more common in patients with subacute infective endocarditis. Janeway lesions, again, more specific for the endocarditis. Those are erythematous blanching macules, non-painful, located on palms and soles aspect of the person. Here you can see septic emboli with hemorrhagic infarction due to acute staphylococcus endocarditis, so which can cause acute endocarditis. Here you can see septic emboli. So if you're suspecting a patient with endocarditis, another physical sign you have to check is rod spots. Here you can see rod spot, central pale, peripheral reddish color area. So using an ophthalmoscope, you have to check for this physical sign. So when you are doing after doing the general examination related to cardiovascular system, then you start to do cardiovascular examination. So here you have to start with pulse. So you have to check pulse, blood pressure, jugular venous pressure, then go to precordium and do the relevant examination. So when you have to check pulse, so you have to check the pulse rate, rhythm, volume, radiofemoral delay, and other pulses. So rate, whether it's a bradycardia or tachycardia, normal heart rate is 60 to 100 beats per minute. If it is less than 60 beats per minute, it's a bradycardia. If it is more than 60 beats per minute, it's a tachycardia. Rhythm also very important. Check whether patient is a regular rhythm, irregular rhythm, whether patient is having regular with some missed beats. Likewise, you have to assess the rhythm. Volume is important. Some disease condition you can diagnose by just palpating the volume. If it's a low volume, whether it's a slow rising pulse, you have to assess the volume. If it's a high volume, then you have to think whether it's a hyperdynamic circulation. Measuring blood pressure is very important in day-to-day practice. Remember, in your exam also, you maybe need to check the blood pressure. So learn how to check the blood pressure properly. So use the sphygmomanometer which is appropriate, and then you have to connect the cuff to the mercury or Android manometer, keep the stethoscope of the brachial artery, inflate the cup, and then you should know how to take the readings correctly. So what are the pitfalls in blood pressure measurement? If the apparatus, if you are not choosing the correct apparatus, you can get the wrong readings. If the cup size is small, then you will overestimate the blood pressure. If you have used the large cup, then you will underestimate your blood pressure. And also calibration of the sphygmometer also very important. And other things like patient factors can also give rise to wrong reading of the blood pressure. For example, emotional state of stress of the patient, anxiety can give rise to higher reading. And again, the observer factors also uh, gives rise to some misreading of the blood pressure of the patient. So jugular venous pressure is an important physical science again, and you have to observe right side of internal jugular vein. In when patient should lie down uh, at 45 degrees. Then you have to observe whether patient is having elevated jugular venous pulse. So you need to have a good and regular practice to identify the jugular venous pulses. And so, what are the causes for raised jugular venous pulse? Right heart failure, tricuspid incompetence, pericardial effusion, superior vena cava obstruction, constrictive pericarditis, tricuspid stenosis. Remember, jugular venous pulse are very common MCQs in your exams. So these pictures shows the way of measuring the jugular venous pressure. Patient has to be lied down at 45 degrees. You have to take the vertical height from the sternomastoid junction, and it has to be a vertical height. So common waves patterns are the A and V and X and Y wave patterns. These are the first and second heart sounds. After completing pulse, blood pressure and jugular venous pressure, then you will come to the most important part, that's a precordium. Again, precordium, you have to do the inspection, palpation, auscultation. What are things you are going to inspect? See whether the precordium is normal looking or abnormal looking. See whether there are any visible scars. See whether there are any palpable or visible or palpable uh, abnormal sounds or any murmurs. By looking at this picture, you can see this tiny boy is having midline thoracotomy scar. This elderly man also having midline thoracotomy scar. Remember, these days we do a lot of interventional surgeries for cardiovascular system. So you will come across a lot of people with this kind of scar in your exam. So if the scar is midline, so think whether patient had a coronary artery bypass grafting or some valvular replacement. Sometimes you will see submammary scar here is a valvulotomy scar. It's a commonly seen in a patient who had a past history of rheumatic fever and the patient who undergone the mitral valvulotomy. And this area you may see the cardiac devices like pacemaker or cardioverter defibrillator insertion. So remember midline scar, submammary scar, and insertion of pacemaker. So the implantable cardioverter defibrillator you have to check during inspection. Inspect for the visible apical impulses. Usually you see in submammary region here, and then you have to look for the palpable heart sounds and the murmurs. So the first thing you have to locate is the apex beat. It is the lowermost and outermost point of the cardiac impulse. Normally it is in the left left-sided fifth intercostal space at the mid-clavicular line. When this space suggests the cardiac enlargement. Heaving apex you can get in the left ventricular hypertrophy. Tapping apex you can get in patient with mitral stenosis. Tapping apex is due to palpable first start sound. So then look for the left paraesternal heave, which indicates right ventricular hypertrophy. Look for palpable first and second sound. Palpable second sound indicate the loud pulmonary heart sound or aortic heart sound. Trills are palpable murmurs. So check for the trills in four cardiac areas. When you are auscultating, use the diaphragm of your stethoscope for a high frequency sounds, bell for the low frequency sound. And normally what you hear is the close of valves. S1 indicate close of mitral and tricuspid valves. S2, there's a second heart sound indicate if the second component of the first heart sound indicate the close of the aortic and pulmonary valves. Second heart sound indicate the close of aortic and pulmonary valves. This is the first sound. This is the second sound. So in between first and second sound is a systole. Between second sound and the first sound, that duration is diastole. So again, aortic component normally louder than pulmonary component. Mitral component normally louder than tricuspid component when you are hearing the normal heart sound. Here you can see the normal heart sound you will hear like lup, dup, lup, dup, lup, dup. So where to listen? So if you want to listen to the aortic area of the heart, listen second right side intercostal space. If it's a left side, the second intercostal space is a pulmonary area. Left lower sternal border, you listen tricuspid area, and apical, that is a cardiac apical region, you auscultate for mitral area. So these are the four cardiac areas you have to auscultate, especially as a routine thing. So here, this diagram shows the blue color areas mark the real situation of the your cardiac valves. The pink areas mark the areas you have to auscultate during your clinical examination. So when you are listening, you should have a system. And when you are listening to a chest of the person, first concentrate about the heart sound. First sound, second sound, lub, dub, lub, dub, lub, dub. So lub is first sound, dub is second sound. Between lub, dub, if you hear the additional sound, it could be the additional heart sound or systolic murmur. After dub, that's a second sound. If you hear some additional sound or a murmur, that's a diastolic sound or diastolic murmur. So apart from the per basic heart sound, you can hear click prosthetic valve sound in a patient. First heart sound has a two major component. It is due to close of atrioventricular valves, so mitral and tricuspid valve. So first heart sound is loud in tachycardia, short PR interval, short circuit length in atrial fibrillation, mitral stenosis with pliable leaflet. So remember, these can be asked in your MCQs. Second heart sounds, it is due to close of semilunar valve, that is a pulmonary and aortic valves. Normally two components, that is a A2 and P2 component. Splitting of the second heart sound is seen in inspiration in a normal person. Single second heart sound can be heard in pulmonary atresia due to emphysema, severe pulmonary stenosis. Inaudible aortic component of the second heart sound can be seen in severe calcific aortic stenosis, aortic atresia. Remember, these are common MCQs. Persistent splitting of the second heart sound seen in complete right bundle branch block and mitral regurgitation, and early timing of the first component of the second heart sound. Peak splitting is seen in ostium secundum atrial septal defect, and paradoxical splitting seen in complete left bundle branch block, right ventricular pacemaker, severe aortic outflow obstruction, a large aortic to pulmonary artery shunt. The second sound Increased aortic component is heard in systemic hypertension, and increased pulmonary component is seen in pulmonary hypertension. Third heart sound. Due to sudden limitation of ventricular expansion during early diastolic breathing, and it can be heard in children normally, and patient with high cardiac output also you can hear. In patient over 40 years old, again you can hear third heart sound. ST usually indicates impairment ventricular function, AV valve regurgitation, other conditions that increase the rate or volume of the ventricular film. Fourth heart sound is a low pitch pre-systolic sound produced in the ventricle during the ventricular filling. It is associated with effective aortic contraction and is best heard when the bell piece of the stethoscope. It is absent in atrial fibrillation, occurs when diminished ventricular compliance increases the resistance to ventricular filling, seen in patients with systemic hypertension, aortic stenosis, hypertrophic cardiomyopathy, ischemic heart disease, acute mitral regurgitation. Remember, these can be asked in MCQs. Murmurs. I think you are very familiar with murmurs. So remember, cardiovascular examination is not just diagnosis of murmur. Murmurs are due to vibration set up in the bloodstream and the surrounding heart and great vessel as a result of turbulent blood flow. Murmurs can be from grade 1 to grade 6. And according to that grading system, grade 1 is very faint, heard only with special effort. Grade 2 is a soft murmur. Grade 3 is a loud murmur. Grade 4 is a loud murmur with trill. Grade 5 is a murmur audible with stethoscope barely touching the chest. Grade 6 is a murmur audible even without stethoscope. That is a grade 6 murmur. When there is a murmur, you have to determine the timing, intensity, pitch, site of maximum intensity, radiation, configuration, relationship with the posture and respiration. Three major categories of murmurs are systolic murmur, diastolic murmur, and continuous murmur. Remember, murmurs are checked in your exam when you come to final year exam. So here you can see the summary. This is a normal heart sound, lup, dub, lup, dub. So this murmur in between first and second sound, so it's a systolic murmur and diamond shape, so it is a aortic stenosis can give rise to this kind of murmur. And mitral regurgitation murmur, you can see it's a systolic murmur. Again you can see the not harsh like the aortic stenosis murmur. Aortic regurgitation, here you can see it's a diastolic murmur. So you have to learn to listen these kind of murmurs. These all murmurs will be questioned in the exam. Mitral stenosis, again diastolic murmur, and patent ductus arteriosus can cause continuous murmur. Here I have given some link. You can go to these the YouTube sites to listen to some murmurs, but main way to learn murmur is listening to the normal people and listening to the abnormal people. Other cardiac sound, pericardial rub, also seen in clinical practice. So it is a hallmark of acute pericarditis. So if you go to this link, you can listen to the pericardial rub. So during your examination of the cardiovascular system, to complete your cardiovascular examination, you have to listen to lung bases for crepitation in left heart failure and abdomen look for hepatomegaly in right heart failure. So dear student, during your cardiovascular history taking examination, it is very important to practice every day the routinely. You have to do this. Then only you will get a first-hand skill to take history and examination of cardiovascular system. Here I have given some example of questions, basically true and false type question based on today's lecture. So these kind of question can be possible in your final year exam. The first question, true false regarding normal waveform of jugular venous pulse. A wave is systole, X wave is synchronized with carotid pulse, A wave is seen just before second heart sound, Y wave precedes atrial contracture, C wave is seen during ventricular systole. So read the textbook. Kuman Clark or Davidson is recommended. So find out the answers. Second question, true false regarding jugular venous pulse again. Number one, loss of A wave is seen in atrial contraction. Systolic V wave is seen in mitral regurgitation. Prominent A wave is seen in pulmonary stenosis. Giant A wave is seen in first degree heart block. Decimal signs is speech of constrict pericarditis. Again, these are very common question in the exam. Read and remember. The answers are given here. Thank you very much.